Thank you very much for joining. And actually, I, Dr. Sohan Solanki, Secretary of Mumbai ISA, and I actually am happy to that Dr. Sheetal Dalal, Secretary of Science, is here, and my President, Dr. Sweta Salgam, is also here, and so many EC members from ISA Mumbai all are here in this today's webinar. And this is actually our first webinar of since our we took over as the new committee in December, mid-December. So. Uh, Today's topic actually we choose a trauma topic, and we have two lectures today. So there will be half an hour lectures each, and there will be 15-minute discussion after each lecture. So I will be moderating the first session on the airway management in this maxillofacial surgery and trauma. So for this talk, I have Dr. Pallavi Vagalkar. She is additional professor in State GS Medical College and KEM Hospital, Mumbai, and she has the vast experience in managing this type of cases day and night. So without wasting time, I invite Dr. Pallavi to go about the case, and we can do more discussion after that lecture. Dr. Pallavi, please take over.
Yes, good evening, everyone. I'll just start sharing my screen, and meanwhile, I would like to thank ISA Mumbai Metro and SAMS for giving me this opportunity. Uh, is my screen visible?
Yes,
Yeah,
Pallavi. Yes.
Yes. So thank you, SAMS and ISA Mumbai Metro. My talk is about airway management in maxillofacial trauma and surgeries. So we know that these are the challenging cases, and for this we have to understand what are the facial anatomy, understand what is the injury pattern, and the required airway management techniques, and lastly the extubation time. So, greetings from my institute, St. GS Medical College in KM Hospital, which is celebrating the 100 years. And this is the plastic surgery OT, which is currently I'm working in, and where the maxillofacial surgery or trauma, reconstructive or repairs surgeries has been done. So basically, I have just collected the retrospective data from the anesthesia registers about this trauma cases, maxillofacial trauma, which key tracking will be patients and dates. It's not a sure shot data, but whatever data is available from the register I have collected. So where we can see that male patients are more commonly had been done last year, and main causes of this maxillofacial trauma is road traffic accidents, about 28 cases, and non-RTA falls were there, and assaults were in 4 cases. Then basically, if you see the trauma side, maxillofacial trauma side, mandible is 21 cases, and zygomatic fractures were in 4 cases. If you see the number of airway management procedures, if we retrospectively saw the nasal intubations were done in 32 cases, oral intubation in 8 cases. Patients came with tracheostomy in 3 cases. Submental and retromolar intubations were done. I have seen one cases. If we see the DL scopes and CMAC or FOB being used, CMAC was used in around 15 cases, and 3 cases of FOB were done. Blood loss were checked, but there was no major blood loss in all these cases. Only 700 to 800 ml blood loss was in one patient, so blood transfusion was less. So basically, now today we are going to cover this. My basic reference is this article from the WFSA tutorial about airway management, and all the green charts will be from this article today. As an anesthesiologist, we have to face these patients in emergency and in operative elective cases for a reconstructive surgery or open reduction and internal fixation of fractures. And post-operatively also, we have to see these patients in ICU for the management. So what is the first battle that must be won in these cases? We all know it's a difficult airway. Maxillofacial trauma is a difficult airway. What makes this airway difficult? So there are multiple factors which will be in causing the difficult airway. First of all, there will be nasopharyngeal obstruction because of the base of skull fractures or fractured maxilla displacement, and there is a regional edema because of the trauma. There might be oropharyngeal obstruction because of the large tongue, mandibular fractures which can alter the floor of mouth anatomy. There might be displaced tooth, bone, soft tissue debris which can lead to obstruction. There is aspiration risk also because a patient might be full stomach, so lack of NPO status, accumulated blood or air in the stomach. There might be increased secretions. Also, there might be active hemorrhage because these are superficial arteries, highly vascular region. The trauma cases going into DIC. Also, because of the trauma, there'll be altered tracheal and laryngeal anatomy. The tracheal ring fracture might be there. Will be edematous. There might be false lumen formation when you are managing the airway. Positioning is also difficult in these cases because limited mouth opening, limited neck extension. If there is associated cervical spine trauma, then there will be a collar and manual inline stabilization, which will make your intubation difficult. So let's consider first the anatomical classification of the important maxillofacial bones. And we all know that face has been divided into three parts: the upper face, which includes frontal bone, frontozygomatic process, ethmoid bones. Mid face includes ethmoid, nasal bones, zygomatic process, and maxilla. And lower face includes mandible and TM joints. The suture lines, they function as energy absorbing zone, distributing the traumatic force and protecting the intracranial structures. Basically, the upper face fractures, 33% can lead to dural tears. The lower face fractures, mandibular, they can be unilateral, bilateral, and panfacial, involving all these three facial segments. So, mandibular and panfacial fractures, they present the highest risk of immediate airway obstruction. Lefort's classification of maxillary fracture, as we know, Lefort's 1 horizontal maxillary fracture, which is floating palate, Lefort's 2, which is pyramidal fracture, floating maxilla, and the last one, Lefort's 3, which is craniofacial disjunction. These are the fractures where there is highest rate of CSF leak due to cribriform plate damage. The combination of these three fractures also can be seen in clinical practice. Anatomical consideration: whenever there are frontal bone fractures, complications like pneumocephalus or intracranial hemorrhage might be associated. Excessive bag wall mask ventilation can exacerbate the pneumocephalus. The concurrent anterior skull base fracture, there is a risk of intracranial penetration when you are putting a nasal tube. Mid-face fractures, like they are more prone for airway obstruction, significant bleeding, subacute emphysema. Naso-orbital ethmoidal fractures, there is again a risk of intracranial penetration through nasal passages. Zygomatic arch fractures, sometimes restricted mouth opening will not improve with GA or NM blockade. 50% of the patient with maxillofacial injuries, there will be mandibular fractures, and condylar fractures are more common in the mandibular fractures. But mandibular fractures have a airway impact. In the case, simple fractures, generally unilateral or single breaks, will not have that much impact. But bilateral fractures, the bucket handle fractures, can cause tongue to fall backward, and there might be higher risk of obstruction. Dental impact: the loose teeth can become foreign bodies. Malocclusion will affect your bag wall mask ventilation later on. If there is comminuted fractures, then multiple fragments can create the instability, and there will be difficulty to stabilize this airway. Also, there can be a laryngotracheal trauma. There might be ecchymosis and hematoma, visible bruising or swelling in the neck region that can progressively enlarge, which will threaten the airway. Stridor or hemoptysis, the audible breathing sounds, bloody sputum also can suggest a severe trauma, which will require immediate attention. Voice changes like hoarseness or inability to speak can indicate the laryngeal involvement. Laryngeal tenderness, pain with palpation over larynx also can precede more severe symptoms. So we have to maintain a very high suspicion for laryngotracheal injuries based on the mechanism of the trauma. So if these articles gives us a big chart of mechanisms of maxillofacial injuries, basically anesthetic point of view, if there is blunt trauma, maybe in the cases of RTAs, falls or assaults, there might be linear facial fractures, dental injuries. So there might be anesthesia concern will be there will be airway obstruction, restricted mouth opening, difficult mask ventilation. If there is penetrating trauma because of gunshot, stabbing, projectiles, there can be again, there will be rapid airway compromise, and later on there will be complex reconstructions in these cases. blast trauma, maybe primary blast wave or a secondary debris. Ear, sinus injuries will be there, penetrating injuries will be there. Again, the airways will be involved. So, mechanism of injury we have to consider. Like again, these are the cases from the online literature. Penetrating injuries, there might be cartilage fractures, blunt trauma injuries will cause air pockets and bilateral vocal cord hematoma. Crushing forces also might lead to vocal cord damage. So, what are the challenges in maxillofacial trauma? First of all, there can be anatomical distortion. The visualization and instrumentation placement itself will be difficult. Lepo's fracture may displace the maxilla posteriorly, obstruct the nasopharynx. There will be bleeding, hemorrhage. This is a high vascular structures. The visualization will be obscured and increase aspiration risk if there is ongoing bleeding is there. The special suctioning techniques will be required. Cervical spine concerns. Immobilization during airway management will further complicate your access. The standard positioning maneuvers might not be possible. And again, the delayed airway compromise even after initial stability. So we have to do vigilant monitoring. The five critical situations that lead to airway compromise in facial trauma is first of all maxillary displacement, which narrows the nasopharyngeal space. Then mandibular instability, as we saw, there might be tongue fall and obstruction. Direct occlusion because of blood secretions, foreign body, which will physically block the airway passages. Hemorrhage, again from open veins or fractures. And soft tissue effects means the delayed edema also can compress the airway. So basically, they'll be in the airway obstruction and from the outside, extrinsic compression by loss of tongue support, displacement of fracture segment, or retropharyngeal hematoma in cases of C-spine fractures. Now, coming to, first of all, we'll see the emergency airway management in these cases. In emergency, first of all, airway examination will include see the verbal response, which will indicate any altered level of consciousness, any voice changes. Look for the injuries in airway, head, and neck. So that will lead to any missing tooth, dental appliances, or whether there what are the causes of obstruction should be ruled out. Also, we have to see the breathing pattern, chest wall, because there might be associated chest wall injuries. We have to find out any other causes of hypoxemia. Rapid neurological examination is very important because the reduced level of consciousness, decreased cognitive ability, the raised ICT features, then we have to take a instant decision to go ahead with the definitive airway. Verbal response, oral cavity inspection, cervical spine evaluation, and serial reassessment are the key factors in emergency airway assessment. But whenever you are doing this primary survey assessment, high flow oxygenation should be administered to all the trauma in suspected airway involvement. Whenever you are assessing, we all remember or we know our mnemonics of difficult laryngoscopy like Lemons or difficult extraglottic device insertion or difficult bag wall mass mutilation or difficult surgical access. This article also gives us new mnemonics in cases of maxillofacial trauma, that is fold. We have to look for facial distortion, obstruction of the upper airway, limited mandibular protrusion, and displaced or undisplaced fracture. Second mnemonic they give is sales, whether there is soiled airway, airway edema, immobilization of the C-spine, limited mouth opening, or swollen tongue. So these mnemonics can be used as a predictor of the difficult airway. Obviously, advanced trauma life support in all these trauma cases, which includes primary survey, which is our A, B, C, D, E examination, which is followed by secondary survey, which includes ample history, that is allergies history, whether patient is taking any medications, past illness or pregnancy, last meal, and events which are related to the injury. That's the secondary survey. And once the history examination is done, then the complete neurological examination, further diagnostics test and reevaluation should be done as in ATLS survey. But what are the challenges in this assessment, airway assessment, when these patients come? There is a time pressure. There is limited time due to ensuring the airway compromise. There'll be hypoxemia. There'll be other life-threatening condition which has to be done. There is like parallel management of multiple factors. So multiple teams are also involved in this. There is anatomical distortion of the airway. There might be a C-spine immobilization. And another factor is patient cooperation. Patients will be uncooperative and combative patients due to pain, hypoxia, head injury, or intoxication. They limit the thorough examination or your secondary survey. In this emergency era, we can also use the ultrasound, which can be useful in such cases when we have can be useful in identify cricothyroid membrane. We rule out pneumothorax or EFAST or maybe in a vascular access. We can always go nowadays with the ultrasound. Also, our difficult airway card should be ready with emergency as well as the elective cases. So that's the placard or thing, emergency airway management, given in the WFSA article, which includes the ABCD examination. And they mentioned that periodic reevaluation of unsecured airway is imperative because the airway edema can progressively worsen over 24 hours following the trauma. So you have to do reassessment in these cases. Whether whether to go ahead with the airway management, so we have to know whether there is an immediate requirement, as in the cases of there is apnea, respiratory failure, or cardiopulmonary arrest, or there is a reduced level of consciousness. Urgent indication will be there is partial airway obstruction, there is a respiratory distress, if the inefficient ventilation, or there are laryngotracheal injuries which may go into uh, catastrophic complications. So then we should go ahead with definitive airway management and semi-urgent indications like if there is a risk of deterioration during diagnostic procedures, like patient is going for CT scan or a patient requires some sedation or analgesia, then these are the semi-urgent cases. So whenever this facial injury patient comes, first of all, we have to find out the patient is fully conscious or not, whether he's able to maintain the adequate airway. Because unconscious patients, they rapidly suffocate because of inability to cough and because of the tongue fall. Immediately treatment of airway obstruction in facially injured patient, you have to clear the airway, to clear any kind of secretions, blood clot. Position is very important. We have to sometimes awake patients they sit up or a lateral position. Removal of any kind of foreign bodies which has to be done. Control the tongue position because in cases of symphyseal bilateral fractures of mandible or whenever there is voluntary loss of intrinsic musculature is lost, we have to take care to maintain the patency of the airway. And whenever patient becomes deteriorate or unconscious, we have to go ahead with the definitive airway management. So before the definitive airway management, some factors like initial airway management, like positioning, lateral positioning will help to decrease the drainage of the blood and secretion. If there is cervical spine injury, then jaw thrust can be used with the manual inline stabilization. We have to avoid the sniffing position which we give during laryngoscopy during cervical injury. When we are using the basic airway adjuvants like NPA, nasopharyngeal airway, will be contraindicated in basal skull fractures. Oropharyngeal airway, we have to be cautious in patients who have intact gag reflex or vomiting. And suction assisted airway clearing will be required. The rigid suction catheters, dual suctioning will be required. Ventilation strategies, two-person bag wall mask technique can be useful. We have to be cautious when you're using the positive pressure because that may displace the fracture segments. And whenever possible, we have to maintain the spontaneous ventilation. So these initial interventions should aim to establish and maintain the airway patency when we are going ahead for a definitive airway control. So this was the SALAD technique, the suction-assisted laryngoscopy or airway decontamination technique by Ducanto et al., where the rigid suction catheter continuously evacuates the blood and gastric contents that will otherwise obscure your visualization during laryngoscopy. And significantly, it improves first pass success rate in challenging maxillofacial trauma cases. Consideration of positioning, we have already considered the unconscious patient or uncooperative patient. We can make the patient in lateral semifowlus position is also helpful in cases where there's chest wall trauma or there's a traumatic brain injury where it will help to reduce ICT and improves FRC. Awake patients, they sometimes try to be in a sitting position so that will help to decrease drain the secretions and manual inline stabilization in cervical spine cases. Now we have to, pre-oxygenation is important. Hypoxia is a potential cause of the correctable altered mental status. So what about HFNO? We know that it can be useful for pre-oxygenation, but in cases where basal skull fracture, due to the risk of significant pneumocephalus, the high pressure force can be, air can be forced into subdural spaces in the presence of skull-base fracture, so we have to be careful. There's uncooperative patient, they will not allow you to provide the supplemental oxygen or sedation in critically ill patients. They can lead to inadequate respiration or further airway obstruction. So in these cases, we might have to go with the definitive airway plan early. So, what are the definitive airway techniques in these patients? The orotracheal intubation first line, which is where the adequate mouth opening is there. Rapid sequence induction with manual inline stabilization should be done. Nasotracheal intubation options whenever there is limited mouth opening is there. You can use a fiber optic guidance whenever available, but it is contraindicated in skull base fractures. Tracheostomy is a definitive surgical airway in the difficult airway, typically performed in controlled settings whenever possible, while cricothyrotomy will be an emergency surgical airway method. So any of the method will depend upon the specific pattern of the injury, what are the available equipments, what are the skills of the clinician and patient factors. Now, this was a list in this article. Let's go one by one. Orotracheal intubation, if you see, whenever there is surgical access to the oral cavity or there is dental occlusion required or mandibulomaxillar fixation required, orotracheal intubation is not possible because it will interfere with the surgical access. Nasotracheal intubation not possible if there is severe nasal trauma, previous nasal reconstructions or anterior base skull fractures and there is coagulopathy. Also, these special kinds of tubes are required whenever we are considering the nasotracheal intubation. We all know the ring adder North Pole ivory tubes are required in these intubations. Tracheostomy, a part of definitive airway management, is required whenever we anticipate that patient might require a prolonged artificial ventilation or when we have to give anesthesia for extensive surgical repair in certain cases. In post-op patients, when there is extensive surgery, we anticipate edema. Then for the safe recovery, we might have to, go ahead with the tracheostomy. Or following obstruction of the airway with the laryngeal edema, or if there is a severe hemorrhage in the airway, then tracheostomy should be planned. Cricothyrotomy attempts should be done whenever other attempts have failed, and relative ease of locating the cricothyrotomy thyroid membrane and its proximity to skin allows a more easy dissection compared to the emergent tracheostomy. In emergency, cricothyrotomy can be considered. The additional choices of managing the emergent airway, basically the intubating LMAs or laryngeal tubes used by the paramedics, these are the valuable bridge techniques whenever the conventional intubation is challenging, when the surgical airway is not immediately indicated. These are the temporary measures until the definitive airways can be established and whenever possible. So if we see the maxillofacial trauma and ATLS airway focused approach, whenever we suspect, obviously ATLS primary survey should be done. Then if you're anticipating difficult airway like blood secretions, distorted anatomy, limited mouth opening or cervical spine, if the airway is compromised or a massive hemorrhage is there, then we have to take immediate life-saving interventions with awake airway interventions or rapid sequence induction or a surgical airway. Once the airway compromise or massive hemorrhage is not there, then we can go ahead with the secondary survey, like do the detailed facial injury assessment, blood loss or hemodynamic, head and cervical spine evaluation that can be done if there is no life-threatening complication. So if there is after a primary survey, if we see that there are no life-threatening complication, we can directly go to the secondary survey, then plan for anesthesia, how the definitive airway plan will be there. Is there an aspiration risk or how will be the position? And then we can plan a definitive surgical repair. So advanced airway management option includes direct laryngoscopy, wherever the mouth opening is adequate, minimal distortion with RSI and manual inline stabilization. Whenever there is indirect visualization in distorted anatomy, minimal cervical manipulation required, we can always go ahead with video laryngoscopy. And whenever there is severely restricted access, we can go with flexible bronchoscopy or Bullard rigid fiber optic laryngoscopy. And when all these approaches fail or contraindicated, we have to go with the surgical airway. WAFI or a video assisted fiber optic intubation techniques have also been there in literature, where hybrid techniques where video laryngoscopy and a tube which is mounted on a fiber FOB. So both the screens you can visualize and go ahead with the intubation. Also, these advanced airway management options has been mentioned in these cases like FOB, Bullard laryngoscope, Bonfils intubation endoscope, and optical intubating stillets, which can be used in the severely restricted mouth opening. And whenever the skillful clinician is there, these advanced airway management like can be used. Bonfils again for trismus or restricted mouth opening uh, can be placed in the retromolar space. these cases, and intubation can be done. This advanced airway management either will require general anesthesia or awake patients. What are the advantage of general anesthesia? It will give optimal conditions for endotracheal intubation and surgical airway technique. But again, general anesthesia might lead to apnea and airway compromise. Awake patients allows the patient to maintain the airway patency and breathe spontaneously, but it will not possible in emergency settings, and sometimes if really poor conditions, bleeding and all is there, then awake intubation might be difficult. So GA generally RSI allowing quick safe intubation, but required pressure might be cautious in cases of C-spine or laryngeal injuries. Elective sequence intubation in low aspiration risk or uncomplicated airway management can be done. Awake approaches, they require patient cooperation, also adequate anesthesia of the entire airway. Whenever fully in this article, they have also mentioned about the variations of awake intubation technique. So patient can be either fully awake, that means only airway anesthesia has been given. But this is rarely feasible in acute emergency settings where we have to prepare the airway like we do in elective cases. Patient can be lightly sedated, like procedural sedation in addition to airway anesthesia can be given. But again, whenever you're giving sedation in this maxillofacial trauma, you have to be cautious about obstruction and aspiration. And there is awake look, that is fully awake or and lightly sedated patient, where preparation and technique similar to rapid sequence induction is done, but a check laryngoscopy prior to the administration of neuromuscular blockade is done. So that will allow the intubator to get a better sense of degree of difficulty of a laryngoscopy before the NMBA administration. What about awake approaches? When you are preparing an airway, in these cases, presence of blood secretions in the airway can dilute the local anesthetic. They can cause inadequate anesthesia. Airway nerve blocks are often sometimes impractical in severe maxillofacial trauma. The internal approaches of glossopharyngeal nerve or superior laryngeal nerve necessitate the sufficient mouth opening for the adequate visualization and access. While the external approaches, the positioning might be difficult when the recurrent laryngeal nerve and superior laryngeal nerve, you need a extension, so that can be difficult in this severe trauma cases. C-spine and anticipated difficult cases, the patient has to be awake, alert, breathing spontaneously as far as possible. Uncomfortable and anxious patient, we have to give a minimal sedation with extreme caution. Difficult Airway Society recommends giving only one sedative agent as the safest approach, but if necessary, introducing a second agent only if an additional anesthetist is there, so that one second anesthetist will look for the sedation and another anesthetist will look for the airway management. So this was for the awake preparation. This was the emergency cases if the patient is coming for the definitive surgery for the maxillofacial trauma. Now these are like they place this arch bars while the teeth are placed in normal occlusion. The teeth, when wired together, there'll be MMF, maxillary mandibular fixation. Plates can be inserted. There might be zygomatic fracture correction, orbital floor fractures can be corrected. And single fractures, they might not be corrected, but if there are two or more zygomatic fractures which lead to prevention of mouth closure. So we have to be careful in these cases. What are the possible options when securing airway in these cases? Nasotracheal, orotracheal, retrograde intubation, and tracheostomy. In orotracheal, there is retromolar intubation and submental intubation. Nasal intubation, if possible, like if there is no basal skull fracture, lamina papyracea, cribriform plate on CTPNS is intact, you can go ahead with nasal intubation. If in these cases the difficulty is not anticipated, mouth opening is adequate, then we can go ahead with the normal laryngoscopy guided nasal intubation. But in these cases, if there is difficulty anticipated, there is restricted mouth opening, obese patients, then awake intubation is preferred, either fiber optic, VDL, or ATCO2 guided, breath sound guided. The nasal intubation, if not possible, as in the case of skull base fractures, cribriform plate not intact, here also, if oral intubation is feasible, mouth opening is adequate. But in these cases, if you put oral tube, there will not be a surgical access. So we might have to put the tube retromolar or submental. If the difficult airway is anticipated, where the mouth opening is inadequate, then we have to go ahead with awake fiber optic or CMAC guided. or retrograde intubation when there are restricted mouth opening and tracheostomy. So we'll see one by one in quick manner. Retromolar intubation, whenever the oral or nasal intubation not possible, means if there is a correction of trauma, and if you put tube orally, this it will come in the surgical way. So the retromolar space is preoperatively assessed on a 3D CT. Uh, Here, the flexometallic tube is preferred because it will avoid the kinking. And these are the steps. That's a busy slide, but basically, preoperatively assess retromolar space to find out whether the tube can stay in that space. First, perform the standard orotracheal intubation. The conventional technique, we have to secure the airway, and then the appropriate this flexometallic size, preferably smaller size tube which will fit into the retromolar space is put. Once the orotracheal intubation is done, the tube has been is shifted gently from the midline to the retromolar area, and we have to secure the tube properly. Here, intraoperatively, you have to be careful about the kinking, altered respiratory mechanics, the tube blockage, etc. Submental intubation. This is advantages in the cases of if you can't put retromolar space is inadequate. Nasal intubation cannot be done, and mandibular fracture is there. So why to go ahead with tracheostomy? Avoid tracheostomy or tracheostomy will be very invasive in these cases. So submental approach can be done, which will temporarily divert the airway from the surgical field. It will be safe in the skull base fracture injury, and it will take half time less than the tracheostomy. So here also the list of the steps of submental intubation. Uh, Again, submental intubation, you cannot shift the patient on a ventilator if you have to go back to the oral intubation post-operatively. So instead of going into the steps, let's have a video. This case we had done where pan-facial fractures here. Patient has been already intubated with a flexometallic tube orally. Nasal was not possible because cribriform plate was not intact. The surgeon is making a tunnel in the submental region. Here the oral tube is already there, so there has to be a good coordination between the surgeon and anesthetist during these cases, and expert skills are required. Uh, Once the tunnel is made, here now the skill comes in passing the tube. So first of all, we have to pass the pilot balloon of the tube. Uh, Again, we have to be careful during this period. There might be apnea because as the pilot balloon, because this also can be very difficult as this patient was quite obese also. So very much skillful technique we have to use and vigilant monitoring during this period. Once the cuff is passed through the tunnel, the pilot balloon is passed through the tunnel, then we have to pass the endotracheal tube, and in this case that we have to disconnect this ET tube, remove the connector of the ET tube, then occlude the ET tube and guide the ET tube through the tunnel. Once the tube is passed through the tunnel, as we are trying to put, you can see in the video, and again we have to be very careful during these steps because now the patient is not getting ventilated, the tube is disconnected. Yeah, this the part of the tube which is coming out from the tunnel. Remove all the debris which are there and then connect the tube to the circuit. So then the procedure can be done, the corrective procedure, but it cannot be maintained for a long time. After the procedure is over, we have to go ahead with the oral intubation. So that was the case. And just in case if the video was not playing, I had these pictures. Retrograde intubation, that's another technique we saw. Now, the technique is in the case of restricted mouth opening, such that only ET tube can be inserted through the mouth. There is no scope, no room for laryngoscopy. So, in these cases, guide wire or epidural catheter is threaded through a 2-inch needle or 16-gauge cannula, which is punctured intratracheally between first and third tracheal ring. And the guide wire is either come through nose or mouth, and then the ET tube is railroaded over it. So this is the training video we see in ATLS workshops. I hope it is audible. There's a guide wire coming out through the mouth, which is inserted retrograde way. The tube is railroaded. The retrograde intubation in difficult cases where the mouth opening is not there. So we have seen retromolar intubation and submental intubations. Now, retromolar will be not possible in case of restricted mouth opening or retromolar space. Submental will be difficult in the laryngotracheal trauma, gunshot facial injuries, local tissue infections, and whenever there is need of prolonged mechanical ventilation and coagulopathy. And these two techniques, there will be increased resistance and airflow in the endotracheal tube. Chances of kinking, displacement in the intraoperative period will be there. Awake fiber optic not possible if the patient is refusing, uncooperative, there is impending airway obstruction, is grossly distorted anatomy and allergies to the local anesthetic. Not possible in emergency cases. Tracheostomy, we know all the advantages and disadvantages. Basically, it requires skillful surgeon and it will be sometimes a tracheostomy itself is challenging in all these maxillofacial trauma cases. Uh, Picothoratomy is a temporary measure, but it will not be indicated if we require a prolonged ventilation. We have to go ahead with the definitive tracheostomy because picothoratomy will might not have adequate carbon dioxide elimination. SGA devices is not a definitive airway. We know that surgical access to oral cavity, if it is required, that they have to put a dental occlusion and maxillomandibular fixation or surgical airway, supraglottic airway devices will be not a definitive airway management. These cases, as we know, they use the arch bars or the wires or the elastic bands to have a good occlusion, dental occlusion, and the surgeons place these rigid plates to correct these fractures. So when these patients are coming, the pre-anesthesia evaluation will be same as any other major operation. We have to rule out any swelling, missing tooth, pain, trismus, or any arch bar or MMF in situ. Nasal patency should be checked to facilitate nasal intubation. Neurological evaluation in patient with coexisting head injury should be there. Patient might have medical problems like acute MI or acute alcohol intoxication, drug abuse, and any other trauma like cervical spine, intracranial trauma, abdominal trauma, pneumothorax, failed chest should be ruled out. The radiological investigation, generally 3D CT is done on these elective cases, which will give us the fracture site severity, what is the mandibular impaction, is there a retromolar space for retromolar intubation, and also CT brain in cases of a neurological injury. In CTPNS, whenever there is mid-face fracture, we have to see whether the cribriform plate and lamina fabricia is intact or not, because if it is not intact, then the nasal intubation is contraindicated. General principles in the definitive is surgery are these are the shared airways. Then mostly the patients will require nasal intubation, eye protection. Patient can be given head position 10 to 20 degrees head ups. It will decrease the edema and decrease the bleeding. Throat packs, we have to be careful. And we might have to do laryngoscopy at the end of procedure to rule out any bleeding or edema. So they have throat packs have to be removed. Oropharynx has to be cleared at the time of extubation. Prophylactic antiemetics, dexamethasone can be given. Extubate this patient when they are fully awake because they should be able to maintain the airway. Small doses of IV opioids might be required if patients have a lot of pain. The staff should be familiar with all the positions of wires that will hold the jaw together, and there will be wire cutters should be available with the patient all the time if there is obstruction. So checklist which they have given for the airway management. Now this emergency airway management checklist they have given is in these cases, we have to first anticipate the difficult airway. Whether there is increased risk of aspiration or full stomach, we have to consult the senior anesthetist. Thorough preparation, clear plans, backup plans should be there and good communication should be there. Find out such features suggestive of laryngotracheal trauma. If there are laryngotracheal trauma not there, what is the current mental status? Is the patient alert or cooperative? Then we can consider the awake approach. If patient is uncooperative, then the rapid sequence induction can be done. patient is obtended, then he might not require any anesthesia or neuromuscular blockade agent for the airway management. If there are laryngotracheal trauma, then we have to see what is the site of the injury. If the trauma is above the larynx, then cricothyrotomy or tracheostomy can be done. At the level of larynx, incomplete trauma, ET tube can be considered, but tracheostomy if unable to pass the ET tube. If the trauma is complete at the level of larynx, then tracheostomy. And if it is below the trachea, like below the level of tracheostomy, then urgent referral to CVTS surgeon and like the tracheal resection cases we have to do. This is a normal checklist they have given where the important consideration for the emergency airway management is airway obstruction and compromise life-threatening true emergency. Always expect there might be a full stomach. Consider there will be C-spine injury, traumatic brain injuries, laryngotracheal injuries. They may have other life-threatening injuries. Patient cooperation might not be possible. Ideal conditions might not be possible in these cases. So we have to do the full checklist when you are doing when we should be prepared with our equipments and drugs. Our team should be ready, plan A, B, C in cases of emergency. A skillful surgeon who can give a good MILS, perform tracheostomy should be there, and the patient management for and the pre-oxygenation essential monitoring should be carried out. So always neuromuscular blocking agents, or you have to avoid whenever there is significant deformity or loss of continuity of airway or soft tissue is encountered. You always have to anticipate the difficult airway conditions. Elective airway management, they have given this checklist. Now, if there is elective airway management, first of all, anticipate if there is a difficult airway, mouth opening is restricted, lot of edema, yes. Then, if we have to go ahead with awake approach or a video laryngoscopic approach, if the difficulty is not anticipated, then we can go ahead with the general anesthesia normally for the elective cases. Whether there is a risk of aspiration or not, if there is risk of aspiration, then go ahead with RSI or awake approach. And if there is no risk, then we can use elective sequence induction. Now, what is the method of intubation in these cases? We have to see whether there is restricted mouth opening, which is unlikely to improve the general anesthesia and paralysis. And the surgeon has to do intraoral surgery. So, standard orotracheal intubation is not possible. We have to consider nasotracheal intubation. As mouth opening is inadequate, we can go ahead with FOB or a Bonnefill's intubating endoscope for a retromolar intubation. In these cases, as mouth opening is not there, submental might not be possible because submental we have to go back to the oral intubation post-operatively. So this is not possible. Lastly, the tracheostomy can be done. If the surgical access to the air, we have to see the second factor, the surgical access is required in the oral cavity. Obviously, the oral intubation is not possible. We can consider nasotracheal intubation or a retromolar intubation, submental intubation or tracheostomy. Because oral cavity, mouth opening is adequate, we can put oral tube and go back to retromolar. Nasotracheal intubation possible, but if it is not indicated or contraindicated, such as in skull base fracture, then nasotracheal is out. So in these cases, we might have to consider orotracheal or put orotracheal tube and go to retromolar or submental approach. And lastly, if nothing is possible, then we have to consider tracheostomy. Again, they have given this major checklist, and we have to consider this multiple factors.
Dr. Pallavi, can you do it fast because it's already 45 minutes?
Yes, sure. Extubation, lastly, the extubation, we have to consider patient factors like whether there is need of mechanical ventilation or there is a edema or hemodynamic instability, and surgical factors like MMF is there or if there is a prolonged surgery. Then again, there is a checklist, but we have to see that all prior to extubation, we have to pre-oxygenate, use a bite block, do suctioning, ET tube cuff leak test should be considered, NM blockage should be adequately reversed, awake and following commands should be the patient. In these patients, we have to avoid suctioning during the lighter plane of anesthesia. There should be smooth emergence, avoid bucking and cuffing, and avoid excessive pressures. So these are the new guidelines. Again, we know that IDA has come with the new guidelines for the airway management. And in the difficult cases, they have given the steps of extubation also, where they consider the delayed extubation in these cases, where you anticipate any edema. They suggest attempt extubation over the airway exchange catheters or the fiber optic or a wire. So these are the airway exchange catheters where patient is extubated, but the catheter is put in situ for at least 2 hours. And if the patient is not maintaining that, you can always go railroad the tube and intubate this patient. So the four keywords and clinical pause at the end of this session are, first of all, we have to maintain the spontaneous ventilation wherever possible, anticipate the rapid deterioration and have a backup plans in these cases, utilize a team-based approach, and do not delay your transitioning to the surgical airway whenever it is clinically indicated. So it's not a single man's job. We need a team for this, and success depends on the proper preparation, appropriate technique selections, and readiness to escalate. These are my references, and thank you for the patience listening.
Thank you, Dr.
Thank you.
Pallavi.
Sorry, I
I think it
exceeded
was
5 minutes.
a detailed discussion on the airway management in maxillofacial surgery and the facial trauma. So I think you have mentioned all the techniques and the different settings and like in lipo 2, lipo 3 fractures and your submental intubation and retromolar or awake fiber optic or awake tracheal intubation radio language guidance. So I think there's one or two questions in the chat box. So the first question was from Dr. Muthukumar is asking, can saxamethodium be used for RSI in extensive ocular injuries? Do you want to take this question?
I think whenever there is extensive or difficult airway and we are going ahead with this intubation, RSI, we can use
So because
saxamethoxam.
rather because he asking that can scoring be given for RSI whenever there is some open globe injury. So I think
Sorry,
in
globe.
open globe injury we normally avoid because that is there may be some other issues with the increase in the all this thing, and so RSI unless you don't have other option, I think if you have other options you can avoid. If you can't avoid, then in that case you have to take some risk and do things. But open, it is. I'm not sure it is ocular injury with open globe injury or what, but I will still say in that way.
Yeah,
So
no, I
yeah,
missed that
the
the
vitreous
open.
expression with Sakta, yeah. So that is the same. So whenever there is open globe injury, even in those cases, because even the ophthalmologists they avoid giving any blocks, and they always ask that even for a small open globe injury, they always ask that to give for general anesthesia for the repair. So this is always the next question is that how do you remove the ETT connector in flexor metallic tube? So I think it is easier to remove because all the flexor metallic tube they come with the removable ETT only nowadays. It is only
Nowadays they
easy to
come.
remove. Yeah, so it is
Yeah,
Yes,
I
we have
just
been
okay.
using
want
the
to
previous one. Yeah.
I just want to add that when you are trying to retrieve it at the time of change of your airway, at that point of time it is difficult. So it should be tried first, and that
Yeah,
connector, the tube should be made little loose prior itself, and then we
yeah,
should attempt to do it at the time of actually doing the procedure. It is easy. Otherwise, it becomes very difficult. Like how we
yeah,
face today, removing the South Pole connector was difficult. Similarly, these tube connector, you have to remove it prior once and keep
Prior
it.
to the
Then it's easy. Then it's easy.
yeah. And madam, one more thing I want to add about this submental intubation. Like so whenever you try, whenever when anybody tries to do a submental intubation, there is always one in the chance of injury to the salivary duct, which is coming from the floor of mouth. So we always go like 1 centimeter away from the midline and 1 centimeter below the like mandible. So in that way, we can avoid the salivary duct injury because if that duct is injured, then the patient will be having always the problem of the excessive salivation. That is one of the
Yeah,
things that we need to.
that is correct. So it's never the midline, it's little off the midline and generally
Yeah,
on the side opposite to the operative side if it's not bilateral.
yeah,
Then you can do it on the other side. And one more thing I just want to emphasize, which Pallavi has already mentioned, that you must occlude the lumen
tube,
of the
lumen of the tube.
flexometallic tube as you are retrieving it from the submental tract, because if any fat or any other blood clot gets trapped in that, it's just impossible for you to ventilate, and that lumen becomes the tube becomes useless. So you have to see to it that we occlude the lumen as you retrieve from the base of the floor of the mouth to the submental area.
Mental.
And as Sona
Okay.
already mentioned, she is asking for RSI, obviously rocuronium is a better option since we have Sugamadex now. So we can always consider in the opal globe injury that you are trying to discuss. So obviously, yes, rocuronium is a better option. And one more thing I just want to add that all these factors which are there to make you identify the difficulty in airway management, uh, the trauma itself is one factor, but if there are any additional factor like if patient is obese or there is already a restricted mouth opening to start off as a submucous fibrosis which is there. So identify if there are any other factors irrespective of the independent of the trauma which can make it difficult that
So they are
must be
not
considered as
these
well.
are, yeah, anatomically difficult airway, but if associated physiologically difficult airway is there, then that
Yeah,
is more challenging.
yeah, and that added source of oxygen all throughout the peri-intubation oxygenation important to emphasize because anytime if there is any temporary loss of airway also that would help.
So I think we have answered all the questions. This is, yeah. So I think we have already near about 1 hour from the start of webinar. We have one more lecture. So I to moderate that lecture and before that I just want to announce that the ISC Mumbai website is again active. So this is they can go and check that it's www.ismmumbai.in and it is and we just started today only, but we need to add few more things. So it will be fully active in maybe in 2 3 days, but it is active and you can go and see the website. So thank you very much. And now I like to moderate the next lecture. I invite Dr. Srikanta Oak from KM Hospital. She is a professor and she's working in the this neuro anesthesia division. So Dr. Srikanta is there.
Yes, yes, I'm there.
Yeah, yeah. So welcome, madam, and you can please introduce Dr. Dipali Thakur from Sion Hospital.
Her CV. Dipali Thakur is an additional professor from Sion Hospital. The next topic is TBI, and India is considered as a head injury capital, where 1 million trauma-related deaths occur in year, and more than 50% are due to TBI, traumatic brain injury, and it adds to the disability, mortality, and socio-economic burden. I welcome Dipali for the next lecture on the TBI.
Yeah, thank you so much, Dr. Shrikanta, and thank you so much, ISA Mumbai and SAMS for giving me this opportunity to present my experience on this forum. Let me just share my screen. Am I audible?
Yeah, you are audible.
Yeah. And you can see my screen too, right?
Yeah, yeah.
Yeah. So I actually come from the prestigious Institute Lokmanya Tilak Medical Municipal College, which has the biggest trauma center in Mumbai. And it has truly enriched all the generations of not only anesthesiologists, surgeons, to be more confident and equipped with managing these trauma cases. So that's our little data. I'm not going into details of it. So around roughly 3,500 number of admissions we do have in our trauma ICU, which is a 14-bedded ICU. Out of that, roughly 1,800 patients presented last year. This is last year's audit. So they presented with head injury, and out of that, around say 550, 560 patients got operated, and rest of the patients required intensive ICU care. So let's just, before beginning the lecture, let us just focus on this slide with a very fresh example of our Deputy CM's sad demise. we know that trauma has this tri-model distribution of deaths. So we actually can't do anything about these immediate deaths. These are the patients who rarely reach to our hospital and they rarely get any intervention rapidly. But there are significant number of patients which fall in this early category. This purple color represents that. And if we can see on x-axis, these the time duration up to 4 hours, if they are treated properly, diagnosed in time, and intervention is done, ICU care is given properly, then these are the patients in whom we can have a good prognostic recovery. And out of these, if you can see, the epidural hematomas and subdural hematomas are the most commonest ones witnessed. Okay. So we have in trauma, we have a concept of golden hour, right? So golden hour is from the injury to hospital if the time is very important. If correct intervention is received or the correct treatment is received, then the mortality and morbidity can be significantly reduced. So time is very important whenever you are dealing with any trauma patient. Role of anesthesiologist in these traumatic brain injuries can be actually varied. We can be involved in pre-hospital care, airway resuscitation as a trauma team member. We can give our services, anesthesia services within the operation theater or outside the OR whenever they are shifted in CT or MRI suits. And we can also be trauma intensive care specialist and pain physicians for these patients, because these are the patients who are going to require an extensive period of our care in a multidisciplinary manner. So objectives of this talk are, I will be covering etopathogenesis, different types of brain injuries, ATLS approach towards these injuries, general principles of management, mainly medical management, anesthesia management concerns, post-operative care, and a little bit about special population. So to define, it is a damage to brain resulting from external mechanical force, right? The direct impact, it may be rapid acceleration, deceleration injury, blast injury, penetrating injury, or projectile object. Etiology may be varied. So in Mumbai, in our trauma center, majority of the accidents are bike accidents, four-wheeler motorbike accidents, railway accidents, but we do keep getting patients of accidental falls, assaults, rarely blast injuries. And burns, we do have a separate ward for burns. Now, when we are understanding what is the etiology of traumatic brain injury, just by knowing the mode of injury, we can anticipate what all problems the patient may be facing. So let's see what is the mechanism of injury in these patients. It may be either penetrating or blunt injury. So the injury may be because of direct impact. It may be an acceleration, deceleration type of injury, or it may be a shockwave injury in case of blast injuries. There can also be a coup and counter coup mechanism wherein the impact happens and the injury happens exactly at the site of impact and on the opposite side of exactly on the opposite side of the impact. So before moving to pathophysiology, let us just quickly revise our physiology. We all know that there is a Monro-Kelly doctrine which states that blood tissue, brain tissue, blood volume, and CSF volume, they are in a state of they are in a state of dynamic equilibrium, right? So increase in any of the compartment causes alteration in the two or more compartments. And if that doesn't happen, then it will lead to increase in ICP. So any trauma leading to accumulation of blood is going to alter the entire physiology inside the brain, right? Then we have to know what is the normal intracranial pressure, which is 5 to 15, cerebral perfusion pressure, because this is very important in traumatic brain injury to maintain the cerebral perfusion pressure in order to avoid ischemia, infarction, and brain death. We all know that cerebral blood flow, it has a autoregulation range ranging from 50 to 150, right? So the cerebral vessels, they auto-regulate during this range, but beyond this range, there is a complete decline or alteration in the cerebral blood flow. Also, the CO2 also has a major impact. You can see on this green graph, green line on this graph, that CO2 also has a major impact on ICP and it may lead to cerebral ischemia. Okay, so let's see our pathophysiology. Again, coming back to types of injury, the direct trauma leads to primary type of injury. Okay, the trauma happens and that leads to primary traumatic brain injury. But after effects of this trauma leads to activation of immune system, external insults, inflammation, all this gets amplified and it leads to secondary brain injury, and chronically immune mediated response leads to tertiary brain injury. So let's see in detail. Can we do anything about this primary brain injury? Actually, no. It happens at the time of accident, right? So this primary brain injury may lead to some contusions, a disruption of blood-brain barrier, hemorrhage, neuronal axonal injuries, and release of all the mediators of inflammation. After primary injury, there is a secondary brain injury, which actually is modifiable by our treatment. Anything leading to hypoxia, hypotension, hypercarbia, raise ICP, hyperthermia, acidosis, and infection, all this is going to impact the brain and cause further injury leading to secondary brain injury. So this is in our hand whenever, at whichever time zone we are seeing the patient, but avoiding secondary brain injury should be our objective whenever we are seeing these patients, right? And that is how, by handling this, we can minimize the insult and minimize the neurological deficits. Now let's see in detail. There are certain subtypes. So traumatic brain injury, it can be focal or it can be diffuse, right? So the focal injury can have some contusions. We can have hematomas, subepidural, subarachnoid, subdural, intraventricular and intracerebral bleeds may be there. There may be a penetrating injury because of gunshot or some iron rod, uh, like that, sharp object, or it can be a diffuse brain injury leading to concussion, diffuse axonal injury, and shock wave. We saw it earlier. Okay. We also can get a typical shaken baby syndrome. So diffuse injury in small babies, we do get such kind of cases. So let's see what are the different types of hematomas. So epidural hematomas, they are the ones what we have to remember. Depending upon the site, they have been classified. But as an anesthesiologist, we should remember that epidural hematomas are the ones which represent the arterial bleeds. So they can really expand very well, very fast. And subdural hematomas, these are mainly venous bleeds. So they have some time to develop. Subarachnoid hemorrhage and intracerebral hemorrhage. Depending upon the Glasgow Coma scale, these traumatic brain injuries can be classified as mild, moderate, and severe. Okay, so severe ones are GCS score between 3 to 8, and mild ones are 13 to 15. Moderate and severe, this GCS sector actually requires our intensive management and observation. How do they present? So the clinical presentation may range from simple headache, mental confusion, dizziness, altered level of consciousness. Depending upon the impact, the site involved, the brain involved, the presentation may differ. Then there may be vomiting, irritability, and it may progress to coma if the ICP raises. Pupillary abnormalities are commonly seen, changes in size, shape, and response to light. Sudden onset neurologic deficits are very common. Speech and visual disturbances if the areas of brain, uh, corresponding areas are injured. And there may be altered vital parameters. So these patients may sometimes present with bradycardias, tachycardias, hypotension, depending upon the pattern of injury. When we are seeing this type of sign, so that's a complete black eye, raccoon eyes, and that's a battle sign. So we have to anticipate. If we see this, then we have to anticipate that these are the signs of base of skull fracture. Okay, and then we have to remember that nasal interventions may be dangerous in these patients, right? So coming to diagnosis, yes, clinical assessment is very important, GCS score and pupillary reaction. After this is done, the primary imaging, the main diagnosis depends upon the non-contrast CT and MRI. And these are few adjuncts which happen, which we do simultaneously. So how does it, all these different hematomas look on CT? The epidural hematoma, as we have seen, it is above the dura. So it looks like a lenticular shape. Then subdural hematoma, this looks like a crescent shape. Okay. Subarachnoid hemorrhage, it usually follows the pattern of your sulci and fissures. In this intracerebral hematoma, you can see there is a little bit of intraventricular hemorrhage also. Okay, so depending upon the CT finding, actually the clinical presentation and the management varies. This is a patient of gunshot injury which has come to our this thing institute. You can see the trajectory of the this thing, and pneumocephalus can be seen, the contusions can be seen, and depressed fractures can be seen. So it can be a combination of multiple types of brain injury, or it can be a simple isolated brain injury. Okay. Whenever we are dealing with trauma patients, do not forget that head injury can be a part of polytrauma. So a patient, this is also another patient presented to our institute, a severe epidural hematoma with pneumothorax with fracture pelvis. So he was a bike rider and presented to our institute in polytrauma. So we have to remember and we have to carry forward a protocolized approach. So management principles depend upon the, we usually follow ATLS guidelines. Beautiful guidelines are given to handle these cases. Monitoring, I will be covering basic and advanced. In short, surgical interventions, medical management, anesthesia implications, and post-operative care. So coming to our ATLS protocol, everyone has to be well oriented about this because trauma is rising in India and it is the leading cause of death, as we all know. So rather than getting panic, actually trauma resuscitation rooms are actually, they are, if we do not follow certain guidelines, then everything may go haywire. Okay. So to avoid that, we have to do proper primary survey in the form of ABCDE, ongoing resuscitation, secondary survey, and definitive care. Okay. So airway maintenance is always with C-spine control. Dr. Pallavi has covered it really well. Breathing and ventilation, depending upon the type of injury, lung injury, involvement, fracture ribs, we have to decide. Circulation and hemorrhage control and resuscitation goes hand in hand. So even if it is a vertical approach, actually everything is happening horizontal at horizontal level. Disability, neurologic examination actually falls over here. Exposure and environmental control, that is temperature control and detailed log ruling and all those things come over here. Resuscitation we will be seeing, and secondary survey actually this is a time where you will be asking about the history and will be doing head to toe examination. Okay, and then comes the definitive care. So coming to airway management, even though Dr. Pallavi has covered it really well, specific to trauma, traumatic brain injury, let me tell you all that early definitive airway, if your patient has GCS of less than or equal to 8, or there is a loss of protective reflexes, securing definitive airway is very important. Assume cervical spine injury if it is not radiologically or clinically ruled out. Okay, so inline stabilization is mandatory whenever you are intubating this patient. Also, you have to assume that all these trauma patients are full stomach. So, rapid sequence induction is with gentle laryngoscopy is mandatory. Pre-oxygenation to avoid hypoxia is very, very important because that is the leading cause of cerebral injury. Prevent hypotension during inductions because this again is going to aggravate the secondary brain injury. So at receiving, when you are securing airways, having understanding about these principles is very important. So keep your fluids ready and keep your vasopresses ready. Blunting sympathetic response, many a times it may not be possible, but yes, if the patient is having hypertensive response, even in trauma resuscitation room, you may consider giving some opioids like fentanyl or lidocaine. Confirming the endotracheal tube with EtCO2 is must, and securing it is also very important, because after you secure the tube, patient may be wheeled into CT or MRI, which is completely out of your area. So accidental extubations, endobronchial intubations, all sorts of problems we have witnessed. Avoid nasal intubation. I have discussed this if there is a anticipated uh, fracture base of skull. So, as I said, that assume cervical spine injury. So, one of the patient had head injury, EDH with cervical spine injury, presented with bradycardia and hypotension. That's the manual inline stabilization being administered, and that's the cricoid pressure being added. So, these are the assisted intubations. You need 3 to 4 people to have these kind of intubations. And suction and laryngoscopy is suction while doing laryngoscopy, the Salat technique which Dr. Pallavi mentioned, is very very important in trauma, because if you are going to select video laryngoscope for your intubation, then your visibility is grossly going to get hampered if your suction is not working, or patient is bleeding, and the patient may have vomitus in this thing in the mouth. So having a good suction, working suction, is very important. Choice of agents. Yes, if your patient is euvolemic, you may select propofol, but in hypovolemic patients, majority of the times we are selecting etomidate. There are few studies being done using ketamine in traumatic brain injuries, but without much complications, but it requires furthermore studies. About neurovascular blocking agents, yes, suxamethonium we are using within first 24 hours intubations we are using, especially when we are anticipating difficult intubation in this dose. And but wherever we are seeing absolutely herniate signs of herniation or raised ICP, there we are avoiding suxamethonium. It has to be avoided because, and along with head injury, if your patient also has documented hyperkalemia or crush injury, CKD patients, burns patients in their first after this thing, spine trauma patients, you are supposed to avoid them. Beautiful alternative drug, rocuronium, is available, and with the availability of Sugamadex now, our job has become little easy in securing these airways in emergency. Let me tell you that yes, intubations in trauma receiving rooms are to be considered difficult intubations because of all these multiple factors. There may be facial fractures. We had an extensive, elaborate presentation just now. There may be oral bleeding. The airway itself may be disrupted. It is an emergency intubation. You cannot postpone it, right? And these patients are full stomach. So whenever you are securing airways for these head injury patients and unstable cervical spine patients, they cannot be only difficult, but they can be dangerous at times, because the situation may be complicated by hypovolemic shock, and multiple unsuccessful attempts may lead to hypoxia and further airway injury, more so in pediatric patients. Okay. So the most experienced anesthesiologists should be available for dealing with these intubations. And again, in short, I'm just covering DAS guideline, combination of all these guidelines. Basically, when you are anticipating difficulty, anticipate and declare the difficulty early. So we have said that code D, activate it early so that you can get and call for you can call for help early, right? Oxygenation is priority all the time. So pre-oxygenation as well as para-oxygenation using nasal O2 by whichever means available. So nasal oxygen um, through your flow meter or your HFNO can be installed. Plan A in all these, whenever you are anticipating difficulty, video laryngoscope with Guji, mainly D-blade portable video laryngoscopes are available. With Buji is the first choice. We are doing that, and limit attempts because that may lead to further desaturation and trauma, airway trauma. If this fails, then plan B is your second generation supraglottic airways, and failing which you can again try one more time face mask ventilation. But remember, while doing all these things, remember that your patient is full stomach. He has all the chances of aspiration pneumonitis, and that can further worsen the hypoxia, and it can lead to aspiration pneumonitis, and it can worsen the situation completely. Okay, so if all this fails, then declare complete ventilation failure early. So consider front of neck access early by cricothyroidotomy, and always confirm ventilation with 6 point wave capnography, which has been recently added in IDA. And securing these devices is very, very important. Coming to ventilation, wherever these patients we are maintaining, we usually should practice lung protective ventilation strategies, assuming that they may be having some lung contusion, fractured ribs, and there may be some aspiration pneumonitis, and neurogenic pulmonary edema has also been well documented. So, assuming all these things, anticipating all these things, lung protective strategies should be initiated right from the beginning. Mandatory ETCO2 monitoring, maintain normocapnia. So all these guidelines, BTF guidelines and ACS guidelines, TBI guidelines actually are recommending PaCO2 values between 35 to 45. Okay. Target SpO2 more than 94%. So avoid hypoxia. Again and again, I'm stressing on these because hypoxia and hypotension, these are the two important predictors for mortality. They have been found to be important predictors of mortality in all these patients in multiple studies. Avoid high PEEP because by increasing PEEP, you are decreasing venous return and you are increasing ICP further. Okay. So unless required, we do not give high PEEP in these patients. Avoid swings in PaCO2 during transport, during positioning, during induction. Okay. Hyperventilation, when we can give. So it is not a routine strategy anymore nowadays because low PaCO2 causes cerebral ischemia. We don't want that, right? So only for impending herniation, where we are, actually you are buying time till the definitive measures are taken care of, or till your osmotherapy works, or till the patient is posted for surgery. So for a very short duration of time, temporarily, you can maintain PaCO2 levels between 30 to 35, and it has to be immediately stopped once the ICP is controlled, right? So coming to circulation and resuscitation. In these patients, the systolic BP targets have been shifted from 90. The Brain Trauma Foundation actually has given very beautiful guidelines. 2007 guidelines had these targets of 90 mmHg as a systolic BP, but now it has been shifted to 100 to 110 mmHg. So just for the age group of 50 to 70, they have a target of 100, and below and above, the target of 110 has been redefined because, as I said, it is the strongest predictor of mortality. Okay, and whenever you are managing or resuscitating these patients, keep in mind that you are not just targeting values, you are also keeping in mind the cerebral perfusion pressure. Okay, so the target for this is set as 60 to 70 whenever we are monitoring. Okay. Control bleeding, which is very essential because in trauma, hypotension is equivalent to hemorrhage until proven otherwise. Okay, so yes, your patient has traumatic brain injury, but if he's bleeding actively, you have to control it first, right? Give isotonic crystalloids as in resuscitation fluid. Give blood if your patient is bleeding, and start noradrenaline early if your mean arterial pressure is falling below your targets. Avoid fluid overload in these patients because it may increase cerebral edema and it may lead to ARDS. So correct the contributors whenever you are doing resuscitation. Correct the contributors like anemia, hypoxia, acidosis, coagulopathy. If there is pneumothorax, then you need to simultaneously insert an IC. Okay. Coming to disability, rapid GCS assessment, documentation of baseline GCS, and monitoring it as a document as a trend is very important, because then only you will able to understand what is happening to the patient, whether he's improving or he's worsening. Pupillary size and reactivity, again asymmetry, mass effect, herniation, you'll be able to identify this when there is an asymmetry. Assess for lateralizing signs, look for seizure activity, and you have to control this under any circumstances, because a single seizure activity increases oxygen demand of brain, and which is not essential. It is which can be dangerous for these traumatic brain injury patients. Also identify the confounders, like majority of the patients, half of the patients, I can say, are under influence of alcohol when they are received in our receiving area. They may be under effects of multiple sedatives or multiple drug addictions. Is becoming, unfortunately, it is becoming very common in younger generation. Hypoxia, hypotension, hypoglycemia. So these three things needs to be corrected before you label that person as a neurological problem. So you have to correct hypoxia, hypotension, hypoglycemia, and then reassess the GCS and pupillary size and document it. Okay. Repeated assessment. So this comes under your secondary survey, right? So just to summarize, I have made this table in which ATLS, Brain Trauma Foundation, and ACS TBI recent guidelines have covered. So we can roughly see that intubate early, secure airway early in these patients, because unprotected airway reflexes, we don't want all that. And these are all the targets for SpO2, SBP, PaCO2. ICP and CPP, yes, the targets have been given by both these are matching. The BTF and ECS TBI guidelines, both targets are matching. Coagulation, we will see in detail in upcoming slides. Okay. Coming to monitoring of these patients, the continuous ASA standard monitoring is important along with ETCO2, core temperature. Along with these, blood glucose monitoring target also has been set as 100 to 180 milligram per deciliter. Earlier studies, they have taken there have been certain studies of tight control, but they did not find any promising results. Rather, the chances of hypoglycemic episodes were very high. So we are following these targets for blood sugar. Monitoring of urine output and catheterizing these patients. Many times I have seen that patients are on osmotherapy and they are not catheterized. It may so happen because your trauma ward is so busy. So following a protocol, following adjuncts to your primary survey and secondary survey is very important. Serial neurological examination and ABG analysis to determine oxygenation, ventilation, acid base, and along with this, you do get an electrolyte monitoring also. Coming to advanced management, yes, as in severe TBI, the invasive arterial pressure monitoring is important to measure mean arterial pressure, to document the CPP. Intracranial pressure wherever possible, and wherever the facility is available, is to be monitored in severe TBI cases with abnormal CT findings. Brain tissue oxygenation, jugular venous oxygen, these are all advanced monitoring techniques. I'm not going into details of it, but yes, they do help in management of these patients, and prognosis may be determined and the management may be altered depending upon the values. Okay, coming to ICP monitoring, yes, level 2, level 3 incidents, level 2, level 3 evidence is there. So all patients with severe traumatic brain injury with abnormal CT findings, you should be monitoring ICP. And patients with normal CT, severe TBI with normal CT. But if your patient has two of these factors like age more than 40 or unilateral or bilateral motor posturing or systolic BP is less than 90, then you're supposed to monitor ICP. These are the different modalities by which we can monitor it: subdural bolt, subdural catheter, epidural transducer, intraparenchymal fiber optic catheters, and ventriculostomy. By having ventriculostomy, you can actually drain the CSF, so it can work not only as a diagnostic tool, but it can work as a therapeutic tool also. So whenever you are anticipating or patient has raised ICP, right? So that's the toolbox we usually follow. So head up position, simple. These are actually very simple techniques, but they are difficult to follow in ICU, especially if your ICU is very heavy. Okay, so maintaining these patients in 30-degree, 20-degree head up position once they are hemodynamically stable. Neutral positioning of the neck is very important to facilitate the venous drainage from head and neck. Sedation and analgesia, normocapnia, osmotherapy, and treating fever and seizure is very important. So this is a tiered approach. So tier 0, tier 1, tier 2, tier 3, we can see this is the basic care which all the patients should receive. So oxygenation, normocapnia, analgesia, this is the basic care all head injury patients should receive. Tier 1, if your ICP is rising, then try with osmotherapy, hypertonic saline or mannitol, CSF drainage if EVD is present. Tier 2 is optimized ventilation, monitor CPP, optimized CPP, neuromuscular blockade may be instituted, and mild hyperventilation, short-term hyperventilation will be tried. And Tier 2 is, this is just a rescue therapy. So barbiturate coma and decompressive cranial. Okay. So now coming to which all are the patients who are going to require surgery. Okay, as an anesthesiologist or intensive care specialist, we should know about these details. So patients with EDH, SDH with mass effect, deteriorating GCS, unequal pupils, and raised signs of ICP. Okay, these are the patients who are going to require uh, surgery, and you need to anticipate and prepare these patients so that they can be, you minimize the delay and they can be rapidly transported to the operation theater. Progressive, this is a CT, you can see progressive increase in midline shift. So any midline shift above 5 mm, they say, you should be watchful, and these are actually the indications when you are going to call the neurosurgery. So EDH, any EDH above 30 ml, SDH more than 10 mm in thickness, and midline shift of more than or equal to 5 millimeter. Okay. Refractory ICP, if you are monitoring ICP, then refractory raised ICP above 22 mmHg may also require surgical interventions. And again, the penetrating brain injury, CSF leaks, mass effect lesions, they may require these surgeries. So this is a CT showing normal brain and raised ICP. Normal brain, these are the ventricles, these are the sulci gyri, you can see properly. And in edematous brain with signs of herniation, the ventricles will be compromised, will be compressed, they will be slit-like, and you will not be able to see the differentiation of the sulci and gyri. So there will be diffuse cerebral edema, right? So what all are the interventions which are routinely done for these patients? The craniotomies, evacuations, decompression craniotomy, EVDs can be inserted, and depression, elevation of depressed skull fractures, dural repairs, all these things are done. Okay. Coming to medical management. So while we saw the initial management as per ATLS, we understood what all patients are going to require surgery. Hand in hand, the medical management uh, has to be carried forward. Okay. So which IV fluids to give? Sugar control we have discussed, anticonvulsants, barbiturates. So I will be discussing all these things in short. Fluids in TBI, yes, isotonic crystalloids are the first line of treatment. So 0.9% normal saline and balanced salt solutions can be given. When you are giving only 0.9% normal saline, be watchful about hyperchloremic acidosis, hyperchloremic, hypernatremic acidosis can happen. Okay, so you need to monitor electrolytes in these patients. So goal here of giving this thing is euvolemia, and at the same time you are avoiding fluid overload. About colloids and hypertonic salines, a big no to hypertonic salines. So all your dextrose containing D5 or half NS, unless indicated, we are not going to give this. These are going to increase cerebral edema, right? Albumin, there have been studies in which it has been found out that it increases the mortality in traumatic brain injuries. So controversial results have been found, and it requires more studies. Synthetic colloids, again, have been found to have coagulopathy and AKI, so we are not actually using them. Hypertonic saline and mannitol, yes, it is to be used for ICP control, but not as a routine fluid, right? These are the blood sugar targets. So 100 to 180 millimeter per deciliter we are using, and we are no more using tight control. Hyperglycemia and hypoglycemia both can be detrimental for these patients. One, hyperglycemia may increase cerebral edema, increase risk of infection, and worsen the neurologic outcome. And hypoglycemia may at times cause seizures, direct neuronal injuries, and we have to be watchful about hypoglycemia, especially when you are treating pediatric head injury patients, right? Anticonvulsants, yes, mainly we are using phenytoin and levetiracetam, loading dose followed by maintenance dose, depending upon the requirement. Coagulation, coming to coagulation. So trauma, we all are well versed with trauma-induced coagulopathy, but chances of coagulopathy in traumatic brain injury are also, the incidence is also very high. So reversing anticoagulants in these patients, if the patients are on anticoagulants, you need to reverse it because it is going to increase bleeding. Platelet thresholds for TBI has been aimed to, actually guidelines are saying more than 75,000 per deciliter, but many neurosurgeons and even our center, we are following platelet count of more than 1 lakh before neurosurgical intervention. Hemoglobin target of 7 to 9. Tranexamic acid has a promising result if given 1 gram given in first 3 hours of injury. So these are actually the anticoagulants. So mainly these patients may require, depending upon the values, the either platelets, FFPs, vitamin K, prothrombin complex concentrates. So depending upon what anticoagulant this patient on, whether he's on antiplatelets or anticoagulant, you are supposed to reverse it with appropriate agent, right? This is a beautiful study done with respect to tranexamic acid in trauma, CRASH 2 and CRASH 3 study. CRASH 2 study was done in large number of, both studies are a large number of patients, had a large number of patients with multicentric studies. CRASH 3 study was specifically conducted in traumatic brain injury, and what they found is whenever tranexamic acid 1 gram followed by 1 gram bolus over 10 minutes followed by 1 gram over 8 hours infusion, when it was given within 3 hours of trauma, it was found to be safe and it was found to reduce head injury related mortality, especially in mild to moderate cases. And no significant thrombotic events were observed. So this we are practicing routinely in our trauma ward. Coming to osmotherapy, whenever the patient has raised ICP, giving osmotherapy is essential. So mannitol and hypertonic saline can be given. And usually we are giving hypertonic saline in pediatric head injuries. We need to monitor whenever we are giving hypertonic saline, we need to monitor serum sodium levels 6 hourly, because many a times the serum sodium levels starts rising, and to our experience we have seen that many patients do exhibit metabolic acidosis also. So fluid management, electrolyte management has to be very meticulous when we are using osmotherapy, right? Before giving mannitol, we have to ensure that patient is euvolemic and avoid mannitol if patient is hypotensive or patient is already having deranged renal function test. Okay, so in patients who are in shock or hypotension, you may use hypertonic saline. Okay. Coming to hypertensive treatment. So when are we going to treat hypertension? Yes, not all patients present with hypotension, right? There are some patients like SAH, already hypertensive patients, old age patients, they do present with hypertension. So whenever the systolic BP is more than 160 or 180, with rising ICP and risk of bleeding, there we are treating hypertension. The first line of agents which we are using is labetalol, nicardipine, ismolol, depending upon the situation. And nitroprusside and NTG is usually avoided in traumatic brain injury for the risk of cerebral vasodilatation. Okay, whatever drug you are choosing, please remember that sudden fall in BP is not advisable. So titrate your drug slowly, preferably have arterial line in place, and then monitor. Then only give these drugs. Coming to analgesia and sedation in these patients. So analgesia first, because we are routinely using fentanyl in our trauma patients to control pain, because that is very essential, one of the modality to manage your ICP, right? But be watchful when you are giving doses. Give slow titrated doses. It should not lead to hypotension. Same goes true with sedation. We are targeting a RAS sedation score of -2 to -3. Deep sedation is not indicated in these patients, and propofol and dexmedetomidine can be used in these patients because both of them reduce cerebral metabolic uh, oxygen demand and ICP. However, be watchful that both these drugs can lead to bradycardia and hypotension. So we have to be extremely careful and titrate the drug and dose depending upon the patient's physiology. Avoid larger boluses of benzodiazepines. Antibiotics and daily sedation breaks are actually recommended in these patients. So coming to anesthesia implications, pre-operative phase, we have actually seen all the targets, and so stabilized physiology is very important before transferring the patient to OT. Many times it is ongoing resuscitation, and some EDH patients, because they do present to us in GCS 15 in lucid interval, and suddenly they deteriorate, and we have to wheel in the patient to OT. Yes, but during that time also having a detailed knowledge about physiology and managing and maintaining physiological parameters is our target. Rapid neurological assessment, quick review of CT scans is important to identify what exactly is happening inside the brain. Then only you will be able to titrate your anesthesia, right? Like suppose with patients having major mass effect or midline shifts, then you know which are the patients who are going to crash at induction, and you will be well prepared well in advance. Check all the laboratory investigations which are available. Check for ECG, X-ray, because many of these patients do have electrolyte abnormalities, hyperkalemia, hypocalcemia, hypernatremia, hyponatremia. All the combination of electrolyte abnormalities may be present, and they may have their manifestation of ECG. Confirming blood and blood product availability is very important. C-spine protection, having your difficult airway plan and cart and equipment, appropriate size, as per patient's age, weight is very essential. IV access, we secure to a large wide bore IV access, but yes, art line and central venous access, mainly subclavian veins we are securing for patients who are severe traumatic brain injury, who are going to require prolonged ICU care, who are going to require vasopressors, mannitol. Again, it requires central venous access. Okay, so keep your vasopressors ready at induction, anticipating the uh, hypotension. Optimization of the comorbidity. Actually, we don't have much time to optimize, but yes, in certain cases of chronic SDH, they do come after some time. We do have some time to optimize, then you should be trying to do. Coming to anesthesia drug choices, we have discussed this about the induction choices and opioids and muscle relaxants. Maintenance, propofol infusion can be preferred. It gives very good ICP control. And inhalational agents in lower doses, less than 1 MAC, sevoflurane over isoflurane, desflurane are acceptable, but avoid higher MAC levels because it leads to cerebral vasodilatation. Nitrous oxide usually we avoid because it has a risk of increasing cerebral blood flow and ICP. And especially in patients with pneumocephalus, pneumothorax, all these patients, it is absolutely contraindicated. Okay, so coming to multimodal analgesia options, we should be giving these options to all our patients: fentanyl, tramadol, paracetamol, and scalp blocks wherever indicated and wherever possible. We can use scalp blocks using ropivacaine or levobupivacaine or bupivacaine. Intraoperative, what problems can happen? So actually these patients may have hypotension, blood loss, acidosis, coagulopathy, hypothermia. That's our lethal triad: acidosis, coagulopathy, and hypothermia. The one worsening the other two. Okay, so treating these, continuing the treatment from your preoperative area to intraoperative area to your postoperative ICU is very important. Arrhythmias, yes, intraoperatively, these patients do have tachy or bradyarrhythmias. Sudden cardiac arrest also may happen if there is an herniation on table. And, while doing these cases, a constant communication with your neurosurgeon and with your team is very important. How tense the brain is, whether brain is pulsatile, how much is the blood loss, because especially in pediatric patients, the blood loss may be a very significant problem, because scalp being very vascular. We have seen many pediatric patients with hemoglobin of 5 and 6, and we have induced those cases keeping blood in hand or waiting for blood. So, all these problems we have to keep in mind. And last but not the least, our awareness under anesthesia, because trauma has because of our focus is on resuscitation and maintaining the hemodynamics, the awareness is sometimes it may get neglected. So monitoring the patients for this is very indicated in these patients. Intraoperative targets, these are the intraoperative targets, so ventilation targets and saturation, we have to continue. Hemodynamics, brain relaxation techniques, again, we have to continue perioperatively. Temperature and normothermia is nowadays recommended. No more hypothermia is recommended by various guidelines. Anticipate blood loss and platelet count above 1 lakh is indicated for patients undergoing neurosurgery. Massive transfusion protocol, if your patient also has other injuries, occult injuries, or patient is bleeding and you have activated the massive transfusion protocol, then 1:1, 1:1. We usually follow this ratio in our institute. There are various different ratios available. Depending upon the availability of blood and blood products, we are supposed to carry forward this. So whenever now coming to emergence and transfer and ICU handover, avoiding the third hit is very important. So whenever the surgery is done, smooth emergence from anesthesia is very important. Prevent any coughing, bucking, agitation, hypertensive responses, even at extubation. Tube kinking, anything which is increasing the peak airway pressure is not indicated, and especially this can happen in this stage. Extubate only if it is safe. Otherwise, majority of the patients of severe traumatic brain injury, they go in ICU on a ventilatory management. Maintain targets. Structured handover, detailed handover to your ICU team is very important, because it is an ongoing process. Sedation and analgesia, seizure prophylaxis, and ICP, CPP monitoring is to be continued in postoperative period. And keep low threshold for repeat CT if any neurological changes or damage or is observed in immediate postoperative care. So coming to postoperative ICU care, we do continue with analgesia, ventilation, hemodynamic supports, antibiotics, everything is continuing, but special mention on nutrition support is very important. So day 3 to day 4, we do start with our nutritional support for these patients. Physiotherapy, active and passive physiotherapy, very important, because these are the patients who are immobilized many a times. So proper positioning, frequent change of position is very important. Similarly, DVT prophylaxis. Majority of the times we are unable to give pharmacological DVT prophylaxis in these patients. So mechanical DVT stockings or compression devices is must in these patients. And lastly, stress ulcer prophylaxis. So coming to special population, I'm not going into details of it, but we have to remember we do get patients in all these uh, category. Pregnant patients with head injury, motorbike accidents, or whenever they present to you, you have to know that there is an altered physiology. They may tolerate initially greater blood loss, but it is at the cost of maternal and fetal problems. Radiological investigations, when you are doing, you have to be careful about whether if the female is in that childbearing age group or she is pregnant, then you have to be watchful about that. Fetal monitoring, whenever we are dealing with these patients in your ICU, is to be done. So having a multidisciplinary approach involving gynecologists in the care is also important. Pediatric patients, we do keep getting lot of pediatric head injury patients, fall from height, fall from staircase, and they do come up with severe head injury. Many a times nowadays we have started getting patients intubated outside and coming. So whenever they are coming, please remember that they are having all the principles of our pediatric anesthesia we have to keep in mind. They do have low functional reserve. They are very prone for hypoxia. If they have been intubated somewhere outside, many a times the size of the tube is so mismatched that you have to change the tubes, but subsequent intubations are difficult because of airway edema. So these practical points, they desaturate very fast. They don't give you much time. Slightest amount of blood clot or secretions blocks the tube and ventilation becomes challenging. So they have very poor tolerance to blood loss, prone for occult internal injuries. So mainly injuries to hollow organs as well as solid organs. Duodenal perforations, pancreatic injuries, splenic liver lacerations, all these things are also there in these patients. Elderly patients, again, they come with their set of problems, but please remember that they will be on polypharmacy, antiplatelets, anticoagulants. Assessment may be misleading initially if they are on beta blockers because compensatory mechanisms for the shock may be absent. So they may appear stable, but actually they may be intravascularly, there will be a hypoperfusion. Okay. So having consideration about these special situations is very important. So my take home from my experiences, secondary as an anesthesiologist, what is preventable is secondary brain injury. And we have to work in this direction together as a team. Physiology determines outcome more than drugs in TBI. Use right fluids for resuscitation and even in perioperative management. Individualize the choice of anesthesia as per patient's needs. Airway and induction may be critical moments wherein, hypoxia and hypotension, even the single episode of hypoxia or hypotension can be detrimental. So prepare well, anticipate and prevent complications. And anesthesiologists actually are the outcome modifiers in traumatic brain injury. So as a member of this community, yes, we do have a very responsible role whenever we are handling these traumatic brain injuries, and the outcome is really well when you act in time. So, thank you so much. Thank you once again for this opportunity.
Thank you, Dipali, for that extensive talk with many practical tips. I
Thank you,
think
ma'am.
we I think we can take one, two questions. One, role of steroid you mentioned.
No, I did not mention.
No.
So, steroids
So
earlier, they were, yeah, earlier, actually, just a second. Huh?
now there that guidelines mention
Yeah.
there is no role of steroid.
Yeah.
Okay.
Now the earlier guidelines were having some beneficial role of steroids. So guidelines are not mentioning role of steroid, but yes, in our ICU, whenever it is herniation, gross cerebral edema, maybe for initial, say 12 to 24 hours, we are giving, mainly in pediatric injuries, we are giving for 24 hours, we are giving dexamethasone for these patients. And
And role of Dexmed, I think you mentioned about bradycardia, but sometimes it may be misguiding because of raise
yes,
ICT also.
yes,
So we
yes.
have to limit the dose.
Yes, yes,
And one more point about the supraglottic airway. Generally, supraglottic airway we should use. They are for intubation, intubating
yeah,
supraglottic airway, because
yes,
most of the time we may have to shift the patient on ventilator. And as you
yes,
already mentioned, they are full stomach.
yes,
So
So second generation supraglottic airways, yes, if your first 3-4 attempts have failed, then to buy time to avoid hypoxia, you can use second generation. So IGL and Procil LMA you can use, or intubating LMA you can use, and over
LMA.
fiber optic you can change your definitive airway
Yeah,
before
and
shifting.
manual inline stabilization, it gives intubation difficulty. You already mentioned, so you have
Yes,
to be prepared for difficult
yes,
airway.
yes.
There is only one question: is ICP monitoring mandatory, and how can we do it? Monitor when not using it.
Yeah. So ICP monitoring, as per guidelines, severe traumatic brain injury with CT abnormality, it is they have a good evidence. So we should be monitoring. But if we are not doing it, or if the facility is not there, then what we have started doing is we have started sonographically. We can
Yeah,
actually monitor optic nerve sheath diameter.
it's
That
a
can give you a
non-invasive
rough.
and it gives
Yeah,
you
it's
very
a
good idea.
non-invasive. It gives you very good idea, and you can actually titrate your treatment depending on it is. It is a really very good this thing. About one more thing, I just did not include in my this thing because it was becoming
Yeah, very
extensive.
vast topic.
Yeah, very vast topic. I just tried to cover up major this thing, but we have started using USG ultrasound for volume assessment. So
Okay.
IVC collapsibility, subclavian collapsibility, we are doing in trauma patients because USG is just there. So whenever you are
Yeah,
securing, just see the collapsibility and fluid responsiveness of these patients. How much to give? Because in traumatic brain injury specifically, you have a risk of cerebral edema
yeah.
and ARDS. So there, yes, now all our students, they are trained in monitoring.
Yeah, fluid resuscitation plays a very important role in
Very
the beginning, in the maintenance, and in the ICU also. Last
Yes.
question, tramadol is safe in TBI. Any concern with procedures?
Uh, oh, actually, I need to.
We are not
See the-
using tramadol. We are using PCM. There are better drugs, so we are using tramadol.
Okay.
Okay, I think
Okay.
we can
Yeah.
finish off. Soham, Shweta madam, anybody wants to comment?
If anybody wants to comment, yeah, both the lectures are very, very good, excellent coverage of the topic.
Yeah.
For Deepali, I just wanted to ask one question.
Yeah.
Whether
Yes.
intraoperatively, when we have tight brain,
Yeah.
that is the surgeon's complaint. So how do you tackle that? Do you have the 1, 2, 3, 4 steps to look at
Yeah.
it and take care of it?
Yeah. So whenever there is tight brain, usually we see for the ETCO2. If ETCO2 is going in higher range, we do hyperventilate the patient for momentary period of time. We do give mannitol. We do give if the operating table is given head up position. So these things actually we are doing, and with that hyperventilation and mannitol, usually it settles down, and we do give a dose of steroid also.
Yeah. Yeah. Thanks, Dipali, for that, because that is one of the common troubleshooting situation that we get it many a times. And it comes also as a short note for our students. So, yes,
Yeah,
I
yes.
thought this
Madam, but
is
in head injury patient, they will never complain about tight brain because it is
because
for
open.
decompressive craniotomy. So
Yeah,
generally in head injury, they don't complain about the tight brain.
side brain.
Yeah,
Okay.
Yeah, but in
Yeah.
severe head injury, we do see many a
yeah.
times
Yeah.
But
Yeah.
non-pulsatile brain
for
and
this
severely
Reactive.
decompressive
edematous brain. Yeah, so they do complain about severely edematous brain. Many a times we do repeat a second dose of mannitol also. So the mannitol has gone to the patient before starting this thing, and we do repeat a second dose of mannitol also along
Yeah.
with some this thing. And yes, at that time you have to see that your tube is not kinking. Many a times you have to confirm all that: tube kinking, high your ICP, your plateau pressures, peak airway pressures, all that has to be also rechecked. And extra
Yes,
dose
one.
of analgesia and extra dose of propofol also we do give.
And dexamethasone is generally for the edema only. Steroid like
Yeah.
methylprednisolone, there is no role according to the
No,
Brain Trauma Foundation.
methylprednisolone we are not giving.
Yeah.
Methylprednisolone is only reserved for
Spine injury.
cervical spine. Yeah, spine injuries. In head injury, traumatic brain injury, we are not giving it. So only
Okay.
dexamethasone we are giving.
Okay, so I think we come to the end of the session. There has been good discussion.
Yeah.
And I would like to thank both the speakers, excellent coverage of the topic. I would also like to thank Dr. Amla, Dr. Deepa, Dr. Sona, all of them who have joined for this. I would like to hear any input
Can
from
we
them.
see each other? Can we all have?
A photograph?
Can we all? Can we all?
Yeah. It's always good to capture
our-
because yes. So if you can all put on the video camera, we
Camera
can
for a
just click
Yeah.
we can
Yeah.
click a photograph. For
Yeah.
our documentation also we need one. And I
Yeah.
thank SAMS for giving us the opportunity and
Yes.
supporting the online webinar. And I thank all the audience so that we could have this interaction, very interesting discussion that happened. And very recent updates, both of you have covered, Pallavi and Dipali. So
Thank you, ma'am.
thank you
Thank
so
you,
much for your effort. Thank you for sharing your knowledge and sparing time for this. Yeah.
Thank you so
So-
much, ma'am.
Yeah. Thank you. We conclude the meeting here. Yeah.
Yeah.
Thank you.
Thank you, everyone.
Thank you. Bye, everyone.
Bye. Good night.
Bye. Good night.